Welcome back to Diabetic Foot File, the podcast where we explore science, pathology, and stories behind wounds, infection, and the human body. Like I said, people don't understand that there is a whole universe of wounds, and sometimes they are quite terrifying. I'm your host, Dr. G, and today we're going to dive into another dramatic yet frightening reaction, taking a little pause on the cinematic wound, but we'll get back to that in another episode. And this is a condition where the body pretty much turns against its own skin. The condition is so severe that patients are often treated in the burn unit for this. And the condition is where the immune system misfires so catastrophically that the skin literally detaches from the body. So I feel like people would understand who are more in wound care would know exactly which direction I'm heading in. But we're going to talk about Steven Johnson syndrome. So before we understand Stevens-Johnson syndrome, we need to understand a very important point that the skin is an organ. The skin is an entire organ. It's not just a covering, and that's why people need to understand that wound care is a specialty of us treating an actual organ. And this is the largest organ in the body. And the skin performs several vital functions, such as barrier against bacteria and viruses, fluid balance, temperature regulation, immune defense, as well as sensory perception. And there are three main layers of the skin, which is the epidermis, the dermis, and the subcutaneous tissue. The outer layer, the epidermis, is where Steven Johnson begins to be its destructive process. And when that layer starts dying, then the body becomes quite vulnerable in ways that are very similar to severe burns. So, who first discovered Stevens-Johnson syndrome? It was two pediatricians in 1922. Thank you, pediatricians. They are amazing. Honestly, not just anybody who can become a pediatrician. These are very specialized, very extremely intelligent people who are very kind. It's like they're the whole package, pretty much. Okay, because it takes a lot to treat children, and they have to make special calculations because kids change as they grow, all this jazz. So it's a very amazing specialty, but they're extremely, extremely, extremely intelligent. So it was discovered by Albert Mason Stevens and Frank Cambliss Johnson. Okay, so now you see the Steven Johnson, they gave each other the last name. And they were reported in children who developed a high fever, a severe rash, blistering skin, and mucosal membrane destruction. So early cases were linked to infections of Mycoplasma pneumoniae, but drug-induced cases became more prominent. So some of the famous cases were corticosteroid case in 1950s, early antibiotics and sulfa drugs triggered the outbreaks. Anti-epileptics like phenytonin, okay, notable cases in the neurological ward in the 1960s and 70s, and then there were actual some cases reported from allopurinol in the 1980s, especially in Asia, and they linked that to genetic susceptibility linked to HLA B star 5801 Ale. Okay, is I'm gonna spell it for you. ALLEFE. Okay. So, what are some key drugs that have been known to notoriously start this type of fire, the Steven Johnson fire? Bactrim. Bactrim is the most notable one for this. Allopurinol, common in gout patients, is higher risk in certain ethnicities. Anticonvulsants, like I said, phenytonin, and then NSAIDs that have like oxycam derivative. These diseases are unlike anything the doctors had ever seen, and they describe the patient's skin as those skin their skins were pretty much melting away. So, Stevens-Johnson syndrome is actually a spectrum. Exists on a spectrum of a more severe condition called toxic epidermal necrosis. I believe we covered it in another episode. And the difference between the two, Stevens-Johnson syndrome and toxic epidermal necrosis, is the body surface area that is affected. Okay, so doctors measure the difference between them by using the body surface area. So Stevens-Johnson syndrome, less than 10% of the skin, there is less than 10% of skin loss. There is something called overlap of Stevens-Johnson syndrome and toxic epidermal necrosis, aka TEN, and that usually consists of 10 to 30% of skin loss. And TEN, toxic epidermal necrosis, is classified by having more than 30% of skin loss. But at that stage of toxic epidermal necrosis, mortality rate reaches about 50%, unfortunately. So, what is the molecular biology and the pathophysiology behind Stevens-Johnson syndrome? So, the immune mechanism behind Stevens-Johnson syndrome, it is a type 4 hypersensitivity. So, it's T cell mediated. Drugs or metabolites bind to the keratinocytes, right? That's on your skin, and triggers a CD8 cytotoxic T cells. And this causes a release of something called granulysin, perforin, okay, and granzyme B. And this cause massive keratinocyte apoptosis, which is cell death. So the molecular pathway is the drug metabolite acts as hapten, and that causes T cell recognition, okay, and something called FASL mediated apoptosis, and that will result in a cytokine storm of TNF alpha, IFN gamma, which amplifies the tissue damage. And in diabetics who already have impaired wound healing and are usually in a state of chronic inflammation, it makes their skin even more fragile. So, like we covered a little bit, there is a genetic susceptibility to Stevens-Johnson syndrome. There's your HLA, that's that they test with your genes, okay? So, if you have a susceptibility of HLA B star 5202, it will be like you have a susceptibility to something called like an anti-epileptic, okay? Like carbamide. I'm pronouncing that wrong. And then if you have the HLA B star 5801, they will most likely be from allopurinol. Like it can cause and trigger Stevens-Johnson syndrome. So it's good for somebody to test that for you just in case so that you would know, okay? Clinical manifestations at a cellular level, it would cause full thickness epidermal necrosis, sloughing of the mucosal membranes, and then also something that you wouldn't guess, eye involvement. So conjunctival apoptosis, okay? And so this is one of the most dangerous dermatological emergencies known. So, like I said, what triggers Stevens-Johnson syndrome is mostly triggered by medication. So, common culprits, like I said, things like Bactrim, antibiotics, sulfa drugs, seizure medication, gout medication, NSAIDs. And why is that? Because these medications cause what about these medications? Cause the immune system to attack the skin. The answer lies behind the immunology and the genetics. Okay, certain drugs bind to proteins in the skin cells, and then the immune system mistakes those altered cells for infected or dangerous. And then the cytotoxic T cells launch an attack on the skin, and that attack destroys the keratinocytes, which are the primary cells in the skin epidermis. So, why diabetics and Stevens-Johnson syndrome, why they're at increased risk, okay? Polypharmacology. So, because they take more than one drug, right? They have more exposure to these triggers. Also, diabetics have delayed wound healing, so they are at high risk of infection, as well as most diabetics are immunocompromised. So they have immunocompromised status. So they are at higher risk of severe disease progression of this. And what are some of the complications if a patient who has diabetes has Stevens-Johnson syndrome, necrosis, secondary infection, prolonged hospitalization, and increased risk of sepsis? So we talked a little about the granulosin that acts like a molecule grenade, right? But that is one of the most powerful and most important things when it comes to Stevens-Johnson syndrome, because one of the most powerful immune molecules that are released during this reaction of Stevens-Johnson syndrome. So granulysin, okay, it punctures the cell membrane and causes rapid apoptosis. Other molecules that are involved are, like we said, perforin, granzyme B, and I'm just gonna call it fast ligand. Okay, together these molecules trigger a massive keratinocyte death, and once the cells die, the epidermis separates from the dermis, and the skin begins to blister and peel off. So, what are some of the early warning signs? This disease rarely starts with a rash. Instead, it begins with symptoms that look like a flu. So, fever, sore throat, cough, burning eyes, and fatigue. And this stage lasts about 1 to 3 days, and then the rash appears. So, early symptoms, I want to say syndrome, but symptoms are fever, malaise, cough, sore throat. Then there might be painful skin eruptions like a targetoid lesion, okay? And like we said, mucosal involvement like your eyes, your mouth, and your genitals. And we already talked about the diagnostic characteristics with the percentage of the surface body area involvement. So, like we said, Steven Johnson syndrome, it has to be less than 10% of the skin body surface involvement of skin loss. Okay. When Steven Johnson syndrome and toxic epidermal necrosis overlap with each other, is about 10 to 30%. But if it's more than 10% of the body's skin surface area involved in the skin loss, the diagnosis graduates to toxic epidermal necrosis. It is not Steven Johnson syndrome at that stage. Okay, if it's more than 30% of the body surface area, it is toxic epidermal necrosis. And like we said, when it comes to that diagnosis, the mortality rate is about 50%. Okay. So, like we said, you will have full thickness epidermal necrosis and subepidermal bullae. So they're blisters, big blisters, okay? So with your labs in the CBC, you will see something called neutropenia, okay? And then the LFTs, and then the kidney function. Imaging, mm, imaging rarely is needed for this type of diagnosis. You can do swabs to rule out secondary infection, but you should be on the radar when you see things like that happen. So the rash of the Stevens-Johnson syndrome can begin as a painful red or purple spots. Soon the spots turn into blisters. The skin becomes extremely fragile. And a classic test doctors use to test this is something called Nikolsky sign. Okay, Nikolsky sign. I'm going to spell that for you. Nikolsky, Nikolsky sign. I know I'm pronouncing that wrong. Forgive me. Okay. And this is when the skin, when you rub gently, the outer layer slides off. Everybody's experienced that pretty much. It's like when you have a severe sunburn. Okay. But imagine that along your entire body spreading. Okay. So Stevens-Johnson syndrome does not only affect the skin, it affects the mucous membranes. So things like we said, the eyes, the mouth, the genitals, and the respiratory tract. So patients may develop severe mouth ulcers, bleeding lips, conjunctivitis, difficulty swallowing, and painful urination. Okay. And eye damage can be permanent. Some patients actually do lose their vision, unfortunately. So the body is pretty much in crisis. So once the skin detaches, the body experiences multiple dangerous problems. Like we said, the skin is an organ, the largest organ. It plays a huge role in fluid balance, right? So you will experience fluid loss, electrolyte imbalance, bacterial invasion because you lost that first layer of your skin, right? And these are full thickness, right? And temperature instability because our skin plays a huge role in our temperature regulation. And this is why these patients are often treated in burn units. Doctors manage them almost exactly like a severe burn victim. Okay. So they go to the burn unit when that happens. Their infection risk. One of the biggest dangers when this diagnosis comes about is sepsis. Because without intact skin, bacteria can enter the bloodstream very easily. That's why it plays a huge role to keep your wounds clean, right? And covered and not to like do like people say air out, right? Because the patient becomes vulnerable to staphylococcus infections, pseudomonas infections, because they love water, they love damp places, and fungal infections. They love damp, wet areas. Okay, sepsis is the leading cause of death in patients who have Stevens Johnson syndrome. Like we said, so what happens if Stevens Johnson syndrome goes untreated? Rapid skin loss will cause fluid imbalance and the patient can progress to shock. And then the infection risk skyrockets to sepsis, multi organ involvement, like your kidneys, your liver, and your lungs. And then, like we said, blindness, like eye damage, because blindness from the conjunctivitis. Okay. So, how do we diagnose this? They usually diagnose Stevens-Johnson syndrome based on clinical appearance, medical history, and skin biopsy. The biopsy typically shows epidermal necrosis, keratinocyte apoptosis, and subepidermal blistering. And the doctor will use a scoring system called the SCORTEN. So SCORTEN, SCORTEN, okay, to help figure out if it's 10%, 10 to 30%, or more than 30%, okay? And this also helps predict the survival rate. So treatment, the most important step is to stop the drug that triggered the Stevens-Johnson syndrome. So stop the triggering drug immediately. Every hour matters. Remember, we always say time is tissue, right? And that's why, it is so good to know certain things because it really is messed up when I think about people whose lives have been lost because they couldn't figure out what's wrong, and that's not even like but it's not even that, okay? It's about not being proactive in the patient's care. Like, there are patients who die in the waiting room because people are not paying attention to them. There are people who die because they didn't get rounded on at all, and nobody even made notice of, "Hey, this is happening." And I understand hospitals are overwhelmed, but I worked in a hospital, we all did, but the whole thing is like, this is a service to the people, right? This is a service to the people to help save their lives. This is not something simple like, "Oh, if we don't pay attention to this, the lights turn off." No, a person could possibly die. That's why it's always important to stay vigilant, always important to take care of your patient. Always stay updated of what's going with your patient because it's not fair to the patient. These people are trusting your life, okay? Like putting their life in your hands. They're trusting you with their life. It is really, really, in my opinion, okay? Because I've been there. I've seen medical negligence to the max. It has personally affected me with the loss of my own family members due to medical negligence. Like I keep on saying, it was baffling how negligent the people were with my family relatives, okay? I to this day, I can't get over it, okay? But God says forgive, so forgiveness, okay? But like I said, every hour matters, time is tissue, okay? So be able to see it, okay? That's why it's better to always be cautious and be like, let's rule out the most dangerous ones before saying it's something simple. Oh, it's nothing. Oh, saying it's a little rash, nothing like that. Don't ever say that, okay? But after treatment focuses on supportive care, like IV fluids, they definitely gonna consult wound care to take care of this, okay? Like I said, most of the time, more likely, they will go to the burn unit. They have to, okay? And pain control and infection prevention. With wound care, I mean, okay, so what are some of the advanced therapies? They might go to the ICU unit too, ICU unit or burn unit, okay? And like we said, fluids, electrolytes, wound care, and pain control. What are some advanced therapies? They might do something like IVIG, which is like the antibodies to block the apoptosis, the mediated apoptosis. They can use corticosteroids, which are kind of controversial, okay? But they sometimes use it short term in the early stage because what do steroids do? They weaken your immune system even more, right? Cyclosporine, that helps with T cell suppression, and biologics under study are like anti-TNF alpha therapy. And like when wound care gets consulted, they try to maintain a sterile environment, topical antibiotics for secondary infection, and glycemic control is critical for helping patients to heal. So see, even if the patient didn't have diabetes, glycemic control is important. You see that because it really does. High blood sugar affects and delays your healing. Remember, we say it affects the macrophages, the neutrophil. It causes a lot of immune dysfunction when your blood sugar is way too high. Okay? So, survival and long-term effects. Even after recovery, many patients face long-term complications, like possible chronic dry eye syndrome. I remember this one lady, she had chronic dry eye syndrome, and that was extremely painful. Like the eye drops, the glasses. I think she even had to wear some type of protective contacts to keep her eyes moist. The patients might have vision problems, severe skin scarring, nail loss, and of course, psychological trauma, okay? Because this disease permanently changes some patients' lives. So, why does this matter in wound care? Most of the time they do consult wound care specialist. Okay, so from a wound care perspective, Steven Johnson syndrome is a quite fascinating wound care diagnosis, especially when it is across the whole universe of wounds, okay? Because you have to know it, okay? These are the same principles that they use when it comes to burn treatment, okay? That's why you got to know how to treat burns as well. Because people don't, when they think of wounds, I don't think people, I think sometimes people will put wounds and burns in a completely different category, or they just think like wound care is like sometimes, okay? Sometimes just diabetics and fast venous, but anything that breaks the skin and the wound doesn't heal and there's a high risk of infection, that's wound care. Anything that breaks the skin, okay? So understanding this complex wound syndrome is very helpful. So, Stevens-Johnson syndrome is a reminder of something quite profound, that the immune system is quite powerful. I think everybody understands that. Your immune system is immensely, extremely powerful. We have to do all our best to keep it at its best function and also not to, for it to attack itself, okay? But when it protects us, it saves our lives. But when it misfires, it can be catastrophic, okay? And, like we said, Stevens-Johnson syndrome is one of the most destructive forces when it comes to the human body and the immune system. So I hope everybody liked this episode today of Diabetic Foot Files. If you enjoyed this episode, you can share it with someone you love who loves medicine, science, or mysteries of the human body. And remember, every wound tells a story. And here at Diabetic Foot Files, we love to decode them. And don't forget to take care of your feet because they take care of you.